Hi and welcome. I'm Dr. Robert Glatter, Medical Advisor for Medscape Emergency Medicine. Today I'll be speaking with Dr. Andrew Meltzer, Professor of Emergency Medicine at George Washington University School of Medicine, about a recent article published by Dr. Michael Tachi and colleagues at Boston Children's Hospital entitled ED Visits for Cannabinoid Hyperemesis Syndrome among Adolescents. Welcome, Andrew. It's really a pleasure to have you join me.
Thank you so much. Thanks for having me.
Can you explain for our audience the current understanding of cannabinoid hyperemesis syndrome and the risk factors associated with developing CHS?
It's an unusual syndrome and a little bit paradoxical because often we think about cannabis as being an anti-emetic, and we've known about using cannabis in patients who are receiving chemotherapy for many years. We know that for some people it helps stimulate appetite, but we see that there's sort of a biphasic reaction with cannabis, especially when we're talking about chronic and heavy uses of cannabis, where it goes from being an anti-emetic to pro-emetic. We see these patients in the ER regularly across the country, patients who present with severe abdominal cramping and pain, and then these stereotypical episodes of vomiting, similar to a cyclic vomiting syndrome that people have heard about for a long time. But with this, we're seeing it very associated with cannabis. And what's sort of unique to it is that patients often describe that they get relief from these hot showers and hot baths. That was sort of a clue for us understanding that this might be a distinct entity.
What is it that heat is curative or therapeutic in terms of the nausea and the vomiting? Can you explain a little bit of that?
Yeah, it's a great question. It's something we're still trying to figure out. But essentially, the pathophysiology, as we best understand it, is related to a dysregulation of the endocannabinoid system. So your body has endogenous cannabinoids that it produces. When you start ingesting large amounts of the phytocannabinoids, it sort of messes with that system. So there's receptors all over the body, in the brain, and in the GI tract for your endocannabinoids that are also stimulated by these exogenous phytocannabinoids, like you might smoke in a marijuana cigarette. The best understanding we know of why the heat specifically causes some relief is related to this TRPV1 receptor. So there's a CB1 receptor, there's a TRPV1 receptor, and that seems to be stimulated both by heat and also by this cream that we sometimes use for therapy called capsaicin. But it's not 100%, and the relief that patients get is really only when they're actively in the shower or in the bath. And early on, we saw these patients with compulsive bathing and sometimes even with burns. As soon as they get out, though, the symptoms would often resume.
There's also substance P that plays a role in this that I've read about personally. Maybe you can explain to the audience what the role of capsaicin is in terms of regulating substance P.
Yeah, that's getting into some of the pathophysiology of why this syndrome is unique and different from some of the other GI syndromes that we see, these functional syndromes. Regarding substance P, I'm not specifically sure how that relates to both the pathophysiology and also potential therapeutics. One thing we've noticed with our research as we're looking for different biomarkers that we actually see that this may actually be more of a immunological or allergic reaction. It's one way I describe it to my patients. What happens is they don't really understand of why they've been using this substance for so long, and for the most part, they haven't had major side effects. Now all of a sudden, they're getting these horrible GI side effects. So what I often say is that, okay, you've sort of developed an allergy now to the cannabis at this point. When we looked at some of the blood biomarkers in our patients who have CHS versus patients that don't, we actually see elevations of markers that are associated with allergies. So that's both HLA markers and also some of the markers for IgE receptors also that we think might actually make this more related to something like an IBS, a Crohn's, or even a more specific IgE-related allergic reaction. That's something we're still trying to confirm, but it's some of the early research suggests that.
So is there any role for immunotherapy in some fashion that might be a possible solution in the future?
Yeah, I think that's sort of where we eventually will be going. I think it's way too early to say for that. We do see that in the acute setting, that the anti-dopamine anti-emetics such as Haldol and droperidol seem to work much better than the anti-serotonergic anti-emetics such as ondansetron. Initially, we were quite sure of why that's going on, but it has something to do with the specific receptors that are being stimulated by this chronic long-term use of the cannabis. We see that patients really don't have much effect with Zofran or ondansetron, but tend to get better with the haloperidol or with other related antidopaminergic receptor medications.
In the current study, a 7-year period, retrospective cohort and design, what they found was a significant increase up to tenfold over this period of time. Is recreational legalization of cannabis really an instrumental part of this increase? I'll let you expound upon that, because it seemed to be it was related, but also there are some aspects of the study that showed that it was not related to the legalization.
What's going on across the country is that there's just widespread increased use of cannabis and widespread acceptance of cannabis use. We see market increase across all areas of society. At this point, cannabis is the most commonly used substance. There's more daily or near daily users of cannabis than alcohol. We've told people for a long time that there's this medicinal use of cannabis, that it's very safe. And we generally agree that it's obviously safer than alcohol or safer than opiates. But the question is, what happens with long-term use and chronic use and using high volumes or high potency use on a daily basis, especially when it's starting in the adolescent ages, is what we really don't know. So I think we've sent a real mixed message to the public. And right now, the adolescent community really believes this is a very safe drug to use and uses it in high quantities. Now we're seeing some of the side effects of patients who use it chronically and for a long time. To see a tenfold increase, that's really amazing over less than 10 years. Whether that's from recreational or not, I guess I can't really speak to that. I think we saw increases in both states that had legalized marijuana for recreational use and states that did not, a little bit more increase in the states that legalized it. I think more, though, this is an area where we really need to educate people of that chronic long-term use of cannabis really does have some potential side effects.
The age at which you begin using cannabis is a big factor, and you've talked about this in your research published in the Annals. Maybe you can expound upon the disease burden induced by recreational cannabis, especially at a young age.
So, yeah, we did a survey of 1,500 people who self-reported having Cannabinoid Hyperemesis Syndrome, and we were looking for risk factors for severity. What we saw is that patients who started using regular daily use of cannabis, typically more than 5 times, sometimes 10 times per day, when they're less than 18 years old, had much higher rates of ER visits and hospitalizations. So we do think that patients who are starting earlier are more susceptible to getting some of these worst side effects of Cannabinoid Hyperemesis Syndrome.
In terms of treatment for those who have an addiction to cannabis, are there any viable strategies, medications, different types of therapy? What would be your suggestions?
This is another great area of research. We really don't have any structured ways to treat people with cannabis use disorder. There's a lot of suggestions of how to do that, but we still have a lot more work to do on this. Most of the patients who have Cannabinoid Hyperemesis Syndrome do qualify as having cannabis use disorder. How we get them to stop using. So now that you've developed CHS, you really can't use cannabis at all anymore. It's even exposure, sometimes secondhand smoke will trigger some of these vomiting episodes. So helping people not just decrease, but actually stop their usage once they've developed CHS. And then for people who are using really heavy doses for a long period of time, how do we help them decrease their usage to a safe level so they don't develop this in the future?
Are there any pharmacologic bridges to help alleviate some of the cravings for cannabis in this case?
There's a lot of research going on with this. There's people who are looking at partial antagonists of receptors as ways to help people decrease the cravings. But right now, there's nothing that people are widely using to help with cannabis use disorder or addiction to cannabis.
Has NAC been of any value in any trials that you've seen or other alternative approaches?
NAC is one of the medications that people are researching for this. At this point, I don't think it's definitive that it helps people either with long-term use or with acute or chronic symptoms of CHS, though.
How do you start the process of taking a patient who uses cannabis daily and reducing their use? Is it motivational enhancement therapy? Is it cognitive behavioral therapy?
All those things are a start. I think one of the first things you do is just try to get people to recognize what's causing this. Patients might be really resistant to thinking that marijuana is the cause of their symptoms. Most people go to the ER multiple times, often go to multiple specialists, gastroenterologists, often get multiple CT scans, endoscopies before they get a firm diagnosis. This syndrome can look like a lot of other more organic conditions. It can look like pancreatitis. It can look like gallbladder or small bowel obstruction. Once you've decided that those other more serious surgical causes aren't going on, and you've decided that this is the most likely diagnosis, I think having a real frank conversation with patients, and sometimes they need to hear it from a couple different providers to say, cannabis is really causing this and you really need to stop. For patients who are using for years and 5 to 10 times a day, It's an addiction, but it's also sometimes almost a lifestyle. This is something that they really have to make major changes in their life to try to stop using. These are generally young people, generally in 20s and 30s by the time you see them in the ER at this point, where they're severe enough that they have to come to the ER. When we see them, we typically are able to manage their acute settings, but what we really haven't been able to do is help them come up with a really good strategy of helping them with long-term and decreasing the recidivism of cannabis use and repeat ED visits. That's really what I think we really need to keep working on, whether it's motivational interviewing, like you suggested, or other approaches. I think that's really where the future research is going to be.
Yeah, certainly capsaicin can be somewhat of a bridge to help alleviate some symptoms, but it's not the answer, we know. What about the economic burden of cannabinoid hyperemesis syndrome? Are there any studies that have looked at what we're dealing with here? Any thoughts on that?
I hate to keep not giving you definitive answers, but the epidemiology is also something we're still trying to understand more of. There's not a specific ICD-10 code, which is how we do a lot of retrospective research for CHS. The way we've done most of our research and the way the JAMA study was done is looking usually at two codes. So looking at patients with chronic cannabis use, then also with these sort of stereotypical GI symptoms as well, and seeing whether or not there's an increase in both of those. So looking at it across the country, I think we haven't done the large epidemiology studies where we look at patients who are chronic users, how many specifically develop this. I've seen numbers from 3 to 5% of chronic users develop this. That might be too high given how many people are using cannabis, but it is something we're seeing more and more of. Having those sort of large scale survey type studies with really strong epidemiology rigor is something we still really need. And so getting to your question about what is the cost burden, it's all sort of interrelated. So getting the accurate numbers of the cases and then looking at these cases over time, how many of them are coming to the ER, how many are getting repeat CT scans or hospitalizations, that's really what drives the cost. How many people are missing work? These are studies that we're hoping to do now in our lab, and we're going to be following people for months to years once they get diagnosed in the ER with prospective observational studies, then hopefully try to extrapolate some of the cost of analysis based upon that data.
And I think it's important to also stress the adverse effects of cannabis on the teen brain, the developing brain, and that starting at a young age, some starting at 12, 13 years old, even younger, the psychological effects, mental health effects, not to mention the aspects of addiction itself on a young person's brain. The concerns are multiple, and we have to address that.
It is concerning, and the fact that we've made it so available to young people, while still it's sometimes difficult to get mental health care, sometimes difficult to get primary care, and yet they're seeing this almost on every corner in most cities and being told generally that it's safe. Very hard for young people to limit usage when they're getting some of this messaging. The amount of milligrams in the available cannabis products is just a huge amount. You have cookies with 1,000 milligrams and just very high potent leaves now too.
The potency of cannabis has been increasing over the last decade or so. And we know that's a factor, certainly maybe in the addictive potential. Maybe it was 3 to 5%. We're dealing with strains of 20 to 25% or higher.
The THC milligrams has gone way, way up. That definitely contributes to what we're seeing. So you have people using stronger strains, you have people using it more, and you have people using it for longer periods of time. It's not surprising that we're starting to see some different side effects than maybe we saw 20 years ago or 30 years ago. Remember, this condition was only described 20, 25 years ago in the literature. There's not that many new diseases that we've encountered in the sort of midst of our career, and this is one of them. CHS is just a growing and preventable condition, and it's rising number in youth and adults. And I think we need better awareness to reduce the impact on patients in the healthcare system. And I think we need to prioritize understanding the side effects of chronic long-term cannabis use in our general population now that we've made it so widely available.
Should there be public health messaging too that hasn't, at least in my experience, been initiated?
The research is still developing, so fine-tuning the public health message to the research would be helpful. What would help now is just this growing awareness that long-term chronic heavy use of cannabis is not necessarily safe. People need to be aware of that. And just because it's now legal and legal for recreational use does not mean that it's necessarily safe. As we know in medicine, we often say the dose makes the toxin. When you're taking anything at high doses, you're going to see side effects. So I think that's what we're seeing now. Every single ER doctor across the country now knows this condition. But 5 years ago, this was sort of a novel idea. But now the awareness is getting out. And when I tell a patient that cannabis might be causing their symptoms, it's pretty rare now that they haven't heard it from at least one person before, or even a family member, or thought about it before, that maybe cannabis is possibly a cause. Although 5 years ago, you would get a very vehement reaction to say, no way, it's not the cannabis. I've been smoking for 10 years. There's no way it's
Yeah.
CHS.
The idea also is that people who use it medicinally, say they have neuropathy or they've been prescribed it, are you seeing CHS in that population compared to the recreational population?
I would say generally no. Those patients are taking it at a much lower dose, tends to be supervised by physicians, but definitely not impossible. And for the most part, what I'm seeing is typically young people, recreational, typically smoking too, as opposed to edibles. Although I don't think there's any pharmacological reason why edibles can't also cause it. I just think you're taking generally less of a milligram dose.
And would that apply to tinctures too in terms of potency in any respect compared to a flower or vaping?
If the patient's able to get sort of large milligram doses of THC and able to stimulate those CB1, CB2 receptors over a long period of time, I think those are the patients that are at risk for getting cannabinoid hyperemesis syndrome.
Is it nubolone? Has there been any efficacy demonstrated from the use of this in terms of treatment for cannabis use disorder?
There's a lot of research going on this. It's an active area of research, and it's something I've thought about as a potential way to manage people with cannabinoid hyperemesis syndrome, is potentially giving smaller doses of something like nubolone to help people decrease the cravings and maybe stop the CHS reactions going forward. That's an open question, whether or not the nubolone is much safer. We do see that patients, once they develop CHS, though, any repeat exposures, even small exposures, can then trigger another episode of the vomiting and abdominal pain.
All right. You mentioned that
And
secondhand smoke can be a trigger too, which was kind of interesting to me. Is it the similar mechanism just through inhalation and absorption?
I find that patients just tell me they've become so sensitive to cannabis that even when they smell it, if they're in rooms with people smoking it, they feel themselves getting nauseous, they feel abdominal cramping. They tell me they're
Mhm.
not sure if it's just so strongly associated in their minds that they're inventing this or if this is real. But I've had multiple people tell me that, to the point now where I tell people that you not only need to be careful of not having any yourself, but try to even avoid rooms where a lot of people are smoking, because for some patients that seems to trigger it. Some of our patients, they're coming back to the ER, they're getting hospitalized. So why are they getting hospitalized? They're severely dehydrated sometimes. We sometimes see acute kidney injury. There are occasional case reports of death, although that's not something we would expect from dehydration or serial vomiting for the most part.
Thank you so much for your time. Really appreciate your informing our audience about the risks, and especially beginning cannabis use at a young age being a primary risk factor with frequent use for developing cannabinoid hyperemesis syndrome.